Happy Friday, everybody. Very, very thrilled to share the stage with Prof. Rez. I get more and more excited than I used to because I think Prof. Rez, Prof. Rez has got life going on. And so expecting him on VMR, I was taking it for granted. And now I cherish it every single time. Well played, Prof. Rez. But before we talk about the magician himself, I'd love to pass the spotlight on to the people who are making it happen. And because of how enthusiastic people are, there are two people who are slated to scribe today. Both Masa and Simi. Neither of them need an introduction, though I imagine Masa is more fresh in your minds, having had an outstanding discussion this past Thursday, yesterday. Though Simi was very close in suit, having discussed the previous Thursday. So I'll hand the mic to you, Masa, to say hello, and then pass the mic to Simi.
Hey everyone, I hope you're all having a great Friday. I'm looking forward for the case.
Hello everyone. Nothing makes me happier than R&R session, and Prof. Rez, your YouTube audience is just not lucky enough. They don't get to join us live, and very excited to scribe today.
Oh, you guys are too kind. I'm stopping Prof. Rez from responding to that. Oh, how mean of me. But I'd love to hand the mic to Kritika. Kritika, I don't know if you can unmute since your video's off, but I would love to hear a word from you. Update folks on what you're up to.
Hello, can you hear me?
Yes, loud and clear.
Hi everyone, happy to be here. Happy to do the teaching points today.
I think you're going to have a lot of work cut out with Prof. Rez being here, Kritika, but very, very excited for you to teach us back what you absorbed. The one and only Zachariah is is doing yet another case this week. I think all of you are like, wait, that's not true. He's not the one and only Zachariah. There are two at least in this community. So sorry for botching that intro, Zachariah, but maybe I can hand the mic to you to tell to update folks on how your week has been and jump right into your case.
Hi everyone, I hope you guys are having a great Friday. And I have a very special, not one, but not two, but three cases that I'm going to be presenting. And the reason for grouping them simultaneously was that these are three patients that I saw in very quick succession with a very similar chief complaint, very similar labs, very similar imaging, um, and three different diagnoses, three different outcomes. And I try to condense it in a short form as possible. So I hope everyone enjoys a lot of learning that I extracted from these three cases, which essentially boil down to one chief complaint. But otherwise, I've been okay. Also have a bit of a URI, similar to you, but really excited for today's session.
Prof. Rez, what's the longest you've been quiet in your whole life? Wow, he's keeping the record going. All right, maybe we can get him to talk with your first aliquot, Zachariah.
Awesome, let's get going. Yeah. So like I said, these are three patients that were seen in very quick succession and with a very similar chief complaint. And I'll give the HPI in the second aliquot, but the chief complaint is bilateral lower extremity, symmetrical, proximal, and distal weakness. So bilateral lower extremity weakness.
All right. Thank you, Zachariah. It seems like we have three cases, so we probably have to work quickly through them. Just let us know if we're going too slow. And I'll be brief here because the first branch point is whether we're dealing with objective weakness. This is really important because right now, Rabih, although he is a stallion and runs like 10 miles a day, eats at a acai bowl, like this guy is the healthiest living animal I know. I had to give a little bit of an insult in there. I didn't call you a human. It can't all be positive. And here I am saying that we don't have time and I'm just on tangent saying ridiculous stuff. But Rabih right now might have some fatigue because he has the sniffles, but he's so dedicated to you guys that he didn't call out sick. So the first branch point is really quickly, I would proceed to the physical exam, honestly, before any further data. Why would I proceed to the physical exam? Because if this is just asthenia, then I'm not activating the schema for objective weakness, which is trying to localize the site of lesion from the motor cortex all the way to the muscle. And as you train and you become more competent, you'll realize that your history taking should be hypothesis driven, as should your exam. So I'm just going to leave it at that with the one teaching point. Quickly examine, is it true weakness or is it not? If it's true, then we can start discussing about what bilateral lower extremity weakness actually is.
Well, I think you're muted, Zachariah.
Yeah. So let's go right ahead. So the first case, case A, is a 42-year-old male with no past medical history who presented with acute onset, so around about 10 hours of rapidly progressing lower limb weakness, now progressing to the upper limbs, and the patient is having increased difficulty breathing. And then some bit of history, short bit of history about this complaint was that this was preceded by some diarrhea during the week, vomiting, low-grade fever. That was after he ate something at a wedding. And it was treated at the primary care provider with some unspecified oral medications before being referred to a tertiary center. Case B, a 38-year-old male who presented with 5 days of progressive weakness in the legs, initially localized to the legs, also now spreading to the arms, with a tingling sensation in the feet, and the patient had some falls recently. 10 days prior to presentation, patient had experienced a flu-like illness with some mild fever and cough, and that's it for case B. Case C, 45-year-old female, no past medical history that we had on record. At the time of presentation, presented with a 4-day history of progressive weakness in the legs, which then eventually spread to the arms. And the patient eventually had weakness to the point where she was not able to ambulate. Of note in this history was that she was constipated for about a week and has a past medical history of drug-resistant TB, which was treated in the past, and then also newly diagnosed HIV positive with a CD4 count of 79. And she was started on Bactrim, which is cotrimoxazole, about a month prior to presentation. And I'll stop there for the second aliquot.
Oh, Zachariah, I think that for many people, this is probably overwhelming, as it should be, because that's probably a very good idea to get practice being overwhelmed, since all of us are going to experience that at some point. And for me, if I was taking care of these three patients, I think you're really showing me what happens probably at least for 30 minutes every day in the ER, where I feel so overwhelmed that actually I'm just trying to figure out what the core of the cases are. And the core of all three cases are identical, that the patient has essentially rapid paralysis. And so maybe I can just reflect on that and then pass the mic to Prof. Rez to mop up after my mess and see what unique aspects of each case he's able to remember and add to that blanket approach. And I do think when somebody gets rapid onset paralysis, we often represent that problem only when the patient has intact sensorium. And I want to sort of make that abundantly clear. We would never say this person is paralyzed when they're obtunded, and instead we would be solving the altered mental status dilemma. So rapid onset paralysis often localizes to the brainstem and below, sparing the sensorium. And so essentially we have a lesion either in the brainstem, the spinal cord, the nerve roots, the nerves, neuromuscular junction, and muscle. And so instead of trying to localize the lesion, I think this is where the internal medicine aspect of sudden onset and rapid development helps us. Because what are the things that are truly rapid in onset? The vast majority of things that are rapid in onset are either an obstruction, rupture, or obstruction, rupture, discharge electroactivity, or the sudden onset of a very specific molecule. So I use that to help me try to figure out what might be going on here. And so I'm worried, is there a blockage of a blood vessel or is there compression on a structure? Um, is there a rupture that tends to be not relevant in this case? Is there discharge of electroactivity not relevant in this case? Is there a sudden accident of action of a specific molecule? Absolutely. This is where hypokalemic periodic paralysis comes in, thyrotoxic or otherwise. This is where some exposures are really, really important. So heavy metal overdose, snake envenomation, tick paralysis. There are many, many entities that happen here. So I think the key question for all these patients is, did they have a blockage, vascular or mechanical? Or do they have an action of a specific molecule? And I think the clues will be able to help us figure that out. Of course, in the world of neurology, there's a unique entity that presents quite rapidly, but not quite fulminantly, and that's immune-mediated disease. So the diagnosis of exclusion in all these cases is Guillain-Barré, AIDP. And you'll see that neurologists are often like, okay, wait, um, um, is this compression of the spinal cord or the brainstem? Is this spinal cord ischemia? Is this lead toxicity, acute intermittent porphyria, B12 deficiency, hypokalemia? So what they're saying is there a compression or a molecule? And if not, it's idiopathic post-infectious immune. So I see that being our train of causes. In parallel, we'll have to try to localize in each individual circumstance, and also try to use the individual clues. But with what you're seeing of me rambling so much is right now in all of these people, I'd be asking myself, when am I getting their MRI? But more importantly, which substance can I test for quickly in the lab and or ask the patient if they've been exposed to? All right, Prof. Rez.
That was beautiful. And yeah, Zachariah, I'll be very reflexive in my thinking here. With case A, you almost present the perfect illness script for Guillain-Barré syndrome, which is acute inflammatory demyelinating polyradiculopathy. And I'll just share like a few pearls here. Oftentimes, when we talk about Guillain-Barré, we say it's an ascending paralysis. But it's a bit confusing because if you think about it, it's a demyelinating condition. When we have our axonal polyneuropathies like diabetes, alcohol, we say, oh, that's like an ascending polyneuropathy, right? Affecting the longest nerves first in the feet and then eventually involving the hands. And this distinction took me a while to understand, but Guillain-Barré for sure is ascending clinically, but at a pathophysiologic level, it's not ascending. It's actually affecting everywhere. It might affect the hands, it might affect the phrenic nerve, but the reason you're seeing it first in the legs is because there's more myelin there. That's just a subtlety I wanted to explain because it always confuses me. They're like, oh, this is ascending. But then when you're trying to distinguish demyelinating from axonal polyneuropathy, you're like, wait, axonal, it ascends upward pathophysiologically and clinically, but Guillain-Barré, it's clinically, but not pathophysiologically. And back to Robbie's point, if you think about it, we're trying to distinguish, is this a myelopathy, spinal cord damage, or is this a demyelinating, a peripheral nerve process? If you were to try to affect breathing within the spinal cord, where would you have to hit? Where the phrenic nerve originates, in the cervical spine. How can you hit the cervical spine and not affect the hands or anything else? So in this case, I feel quite confident that I actually don't need an MRI, but I would proceed with an LP because that can add further support if you have albuminocytologic dissociation. But you may say, wait a minute, Reza, how in the world are you getting protein in the CSF space if we're talking about a peripheral neuropathy? And this is where Aaron has taught us the pearl. That's why the term is polyradiculopathy. Radicular. These are the nerve roots. They're they're right next to the CSF. So when they demyelinate, they're going to spill their protein, and that's how you have the albuminocytologic dissociation. And then the other pearl is this. Even if you give IVIG, in this case, I'm really worried, Zachariah, that this person is going to have respiratory compromise. And this is how patients with Guillain-Barré actually die. So this patient needs to be admitted. You might actually measure their negative inspiratory force to see how strong the diaphragm for triage decisions, whether it should be the step down or the ICU. But I'm leaning, in my institution, we would admit minimum step down, probably ICU. But you have to understand this too. I can give this Plex, I can do IVIG, I could do Ritux, but that's not going to cure the person of the problem that's already happening. It just prevents further damage. So I don't expect an immediate response like we might expect with an abscess that we drain. It's just it's basically to put water on the fire, but what the fire has already burned, you can't solve. Dude, it's crazy how great Aaron is as a teacher. Like really, like I hope that someone can tell him to go listen to this first part. Now he's going to listen. He's going to be like, Reza, everything you said is true, but irrelevant to this case. But anyway, the first case, Robbie, for me is Guillain-Barré. And I'm going to have you just comment reflexively too. And then, but maybe you can comment real quick here. Anything to add or anything else that's putting up your spidey senses?
Nada, my friend.
Okay. For case B, this is more interesting in that you're getting tingling, and tingling is a sign of paresthesia. Paresthesia is primarily peripheral neuropathy. And but the mimicker is what Robbie already said, which would be myelopathy. So I think here assessing urinary and bowel symptoms is important, and assessing reflexes. Remember, with Guillain-Barré, we expect hyperreflexia, though in acute spinal cord injury, you can also have acute hyperreflexia. But if someone doesn't have hyperreflexia, that really pushes me away from Guillain-Barré. So in this case number 2, I'm leaning towards some kind of polyneuropathy because it's symmetric, by the way. That's why we're saying polyneuropathy. Acute, and the acute causes is what Robbie had mentioned, like AIP, metal, and Guillain-Barré, but open to a subacute process, which is way more common, that is finally tipping over. The rapid tempo is suggestive of a more exotic, like a demyelinating condition than your typical alcohol, etc. But the further physical exam and reflexes, and that will help guide us whether we're really dealing with a peripheral process versus a central process. Robbie, anything to layer on part B? Anything? All right. For part C is the most interesting one to me, and the one that makes me pause. One, because I don't take care of patients with HIV, and so I can't be as reflexive, and I have to temper like what I think is going on. But what I do know in that landscape is all of a sudden this patient is going to be at risk of both opportunistic infections and opportunistic malignancy. So I'm curious, are they taking their antiretrovirals? What's their current CD4 count? What's their viral load? If they are taking it, have we just unmasked something in the central spinal cord in an infection? Or is this iris just an immune system revving up because we're reconstituting it? So part C, I think there's a lot more to unpack. But in addition to the exam would be the CD4 count, the viral load, knowing are they taking their antiretroviral, and being open that maybe we are dealing with a myelopathy either through iris or an unmasked infection. Back to you, Zachariah.
Amazing, wonderful discussion. And in the interest of time, I'm just going to present positive findings. So aliquot 3, vitals and physical exam. So for case A, the patient was in marked respiratory distress, using accessory mufflers and setting at 90% in room A. Systemic exam, unremarkable. Neurological exam was very prominent for the fact that the patient was weak, power 2 out of 5 in the lower extremities, and power 3 out of 5 in the upper extremities, areflexic, so no reflexes, but otherwise preserved sensation, normal bladder bowel function, cranial nerves all intact, and systemic exam otherwise remarkable, just slightly tachycardiac, but no other abnormalities. Case B, patient was again quadriparetic, again predominant in the lower limbs, so power 1 to 2 out of 5 in the lower limbs, and 2 to 3 in the upper limbs, areflexic, also mild respiratory distress, but patient was setting at around 92% on room A. Mild paresthesia is noted in the extremities, but otherwise preserved sensation. Cranial nerves were intact. No neck stiffness, no sensory level. Case 3, patient was tachycardiac, tachypneic at around 24 breaths per minute. Neurological exam, once again, but here it was quadriparetic, power 2 out of 5 in all the limbs, with a bilateral lower motor neuron type facial palsy. Patient was also areflexic, with a clear sensory level at around T4, the absence of proprioception and any sacral sensation, and the patient was noted to have some neck stiffness. And I'll stop there.
Rafrez is pointing at me. Oh my gosh. No. This is a very, very challenging thing to try to figure out, Zachary. As you imagine, you're trying to stop three massive fires at the same time. I think all three patients probably have cardiopulmonary compromise and need advanced treatment. I'd emphasize that when you have hypoxemia in the context of neuromuscular weakness, you are past the point of no return. Neuromuscular weakness initially causes hypoventilation, and the initial abnormality is hypercarbia with normal oxygen saturation. So once you have hypoxemia, either as a result of the hypercarbia or the result of atelectasis from the hypoventilation, your patient's in crisis. So all these patients in my hospital would be admitted to the intensive care unit and probably intubated at this point. In terms of the neurological localization, I think we made in all patients is all patients have a very powerful feature of low reflexes. And low reflexes localize the disease to the peripheral nervous system in the vast majority of instances and exclude muscle disease. Of course, both these statements have some exceptions, and the most notable exception is acute spinal cord pathology, which can cause spinal shock. And however, spinal shock is typically in most people in the context of trauma. And so atraumatic spinal cord diseases often actually cause the reflexes to either be normal or elevated. But that is still a caveat. I think the only person whose localization within the central nervous system, the only case for whom there is really doubt about whether there is a true CNS or PNS process is case 3 because case 1 with the low reflexes and the absence of urinary symptoms is very suggestive of something distal to the spinal cord. In case 2, I think the fact that you have hyporeflexia without a sensory level is nearly there, that it's not in the spinal cord. But uh, in case 3, the fact that you have a sensory level is essentially diagnostic of having a true spinal cord disease. And the tension, I think, in case 3 is how do you reconcile having a spinal cord issue at T4 with the fact that the patient has bilateral facial palsy that is in the lower motor neuron pattern. And I think that creates a dilemma. I think it also exposes the flaw in our reasoning because the peripheral nervous system and central nervous system are discussed as if they are foreign countries, but in fact, in many instances, they are neighbors. And it's an arbitrary division between when the CNS ends and when the PNS begins. And when patients have diseases that have both features in the CNS, like the sensory level, and in the PNS, like the facial nerve palsy, it will probably localize the disease to the subarachnoid space, which is the space between the central nervous system and the peripheral nervous system. So if I were to do one lumbar puncture in this instance, it would be in case number 3, having very high concern that the patient will likely have CSF pleocytosis, explaining the spinal cord pathology and the facial nerve pathology. I think for case number 1, I'm like right there with Prof. Rez, rushing to give this patient Guillain-Barré treatment. For case number 3, I'm rushing to do the lumbar puncture to figure out why they have inflammation in why I worry they have inflammation in their CSF, influenced, of course, by their HIV. In case number 2, I'm intrigued. I'm very, very intrigued. I'm having a hard time figuring out what the next step would be in that case. And yeah, instead of articulating that difficulty, maybe I can stop babbling and see where Prof. Rez is at.
I am right there with you, Robbie. Zero to add. I actually was just checking with GPT whether if you're that suspicious of GBS, do you do an LP or not to add further? I don't know. I mean, I'm using the VA chatbot, which is a little obsolete. It says yes, but if someone can look that up, and or if someone's a neurologist can include that, or I could ask Robbie because you're ED. Do you know, is that if you're very suspicious of it, do you still do an LP or you don't? I just don't know the answer to that.
Yeah, Paraphrase, I don't know if I can confidently say so, but I think that LP can't hurt you. It's a great additional tool. I think that we know really that time is neuron for AIDP, so I think I would have a lower, I would not use an LP to delay treatment. Um,
That's a political response. But you're good at those ones, Robbie. I've been on stage with you, my
yes,
friend.
Paraphrase.
Which D do you want, the dexamethasone or the doxy?
Okay,
Anyway, back to me. Take the mic from us. Keep presenting.
Fantastic, fantastic. So some labs and imaging pertinent findings. Case A, interestingly, electrolytes, potassium was tested. It was 2.5, which was well below the normal limit. Magnesium was tested 1.2, and sodium was 132. All other labs were tested, were all normal. Normal CBC, normal LFTs, normal other, everything else was tested. Patient had an MRI and CT brain, which was normal with contrast. Nerve conduction studies in case A was normal, and CSF tested was completely normal. No albuminocytological dissociation, not even a cell. And that was case A. Case B, once again, labs majority normal. Pertinent labs, pertinent things that were, again, the MRI in case B was normal. MRI and CT brain in case B was normal. The CSF in case B protein show was around 1.1 with one white cell. And I'll leave it at the actual case B. And case C, the patient became, so case A, sorry, just to go back to case A, the patient was intubated in the ER. Case B, the patient was intubated and sent to the ICU. And case C, the patient also became extremely confused and was eventually intubated in the ER. And some pertinent labs in case C was a sodium of 128 and a urine sodium of 83. Pertinent imaging findings in case C was a CT chest, which showed pulmonary embolism, normal CT brain, normal MRI spine. CSF in case C, the protein was 1,25, which is extremely high, no cells. Again, albuminocytological dissociation. And the CT abdomen in case C showed some mild colonic distension. And I'll stop there.
Wow, this is really, really juicy. Zachariah, for case B, is that protein, it's considered elevated, yes?
It's elevated.
1,000, so very high protein. So this is so fascinating. Let's have some fun, Robbie. I'll share reflexive thoughts. This is really, really interesting because the case that was most slam dunk for Guillain-Barré has findings that challenge that diagnostic hypothesis. And luckily, Elena put something really, really cool in the chat. In addition to echoing what Robbie's clinical instinct was to initiate treatment when you're concerned without delaying it, is that sometimes you might not see the albuminocytologic dissociation because it's so early in the course. It's almost like, Robbie, our patient with pancreatitis, or the lipase initially is normal, but then becomes abnormal. So at first I was like, okay, maybe it's just that the case is so strong for Guillain-Barré. But then you look at the nerve conduction study, and the nerve conduction study is normal. Now, I don't think there's a world where you're having this type of degree of paralysis and it's demyelinating and the nerve conduction is normal. So that makes me very strongly question it. But I'm like, okay, then what's my alternative hypothesis? The MRI was normal. there's nothing happening central. And then I look at the potassium, and I see that the potassium is 2.5. Now, interestingly, this is a patient who's having diarrhea, right? Like that everything preceded the diarrhea, and you can expect some hypokalemia with diarrhea because you're just losing a lot of volume and you're activating the renin, angiotensin, aldosterone system. But boy, you got to have a lot of diarrhea, et cetera, to do that. And all of a sudden, hypokalemia becomes a very attractive alternative hypothesis, a condition known as hypokalemic periodic paralysis. And then I was like, well, what about the reflexes? Because we often talk about when someone has muscle pathology, right? The reflex arc is intact. If you have inflammation of the muscle, the reflex arc is intact. However, you can imagine if someone's muscle is not functioning because of a very low potassium, they can't contract. So even if the reflex arc is intact, it won't contract. So I don't think the areflexia pushes me away from the hypothesis of hypokalemia. So I'll be honest with you. I think the nerve conduction setting being normal, there's no albuminocytologic dissociation, and I have a good alternative hypothesis, a very low K. I'm leaning towards hypokalemia as the main culprit in case A. What I would do is I would replenish it. But remember, if the MAG is low, you're not going to be able to replete the K because a low MAG leads to incessant activation of ROM-K channels and the distal nephron. So you really need to replete that magnesium to be able to replete the potassium. That being said, could this be a tricky Guillain-Barré syndrome? I have no idea, but I'm rising up hypokalemia. I'll see what Robbie thinks about that. And if this is all hypokalemia, it should get better. But then the question is why hypo? I think we do have a good explanation, and that's all the diarrhea that occurred, as opposed to it being like thyrotoxic periodic paralysis, or like trying to seek another etiology. So let me just stop there because I think there's so much to unpack here, and then we'll go. And maybe Robbie, you can comment on case A and then lead off B, and then loop me back in.
Aye, Captain. Gonna show a picture. Guys, I'm feeling too tired mentally to use my brain alone, so I'm gonna use some schemas. Only one schema. This is what I do when I'm tired. Like, I already thought about this. Why am I thinking about it now? Okay. Are we missing a substance in K1 in case 1? Yes, it's potassium. The most common reason why people get hypokalemic periodic paralysis, distinguishing them from the hundreds of people who have a low potassium and don't get paralyzed, is thyrotoxicosis. So I think that that definitely is crossing my mind for case 1. But I'm also right there with you, Prof. As most people who have hypokalemia causing their paralysis should get much better very quickly. It's also possible that the potassium is a distractor. Most people with hypokalemic periodic paralysis should not have hyporeflexia, as far as I understand it. It's a muscle problem. So that's my one caution. For case number 2, Prof. Rez, I think that there's no reason to suspect. We haven't found a substance yet, either a deficient one or one in excess. So I'm getting closer and closer to the destination diagnosis of Guillain-Barré, especially with the albinocytologic dissociation, and would probably empirically treat the second patient now. I do not regret at all empirically treating the first patient because Guillain-Barré life is time is neurons. And for the first case, Prof. Rez, I think I'm starting to worry there might be a substance at play here. Just based on the fact that we've looked and imaged and found nothing. Yeah, but I'll stop there. We can reflect more on that, but I'm just cheating now and using the scheme.
So Robbie, keep this page up, please.
Yes, Captain.
I actually I threw in GPT this question about the reflexes.
Oh, yeah.
And what it said is that like during the acute episode with hypokalemia, even if you tap the reflex arc, the muscle won't contract. So that also surprised. So I wanted to verify that. So maybe that adds further support to hypokalemia hypothesis. I think B, I have 0 to add. I think C is the one that is quite interesting. And Zachary, can you remind me what was it with C? It was that what were the findings?
Here, I'll reshare the screen.
Oh, thank you. Thank you, Captain. All right, never mind, Zachary. I can see it right here. Yeah, case C is the most concerning because this is not just a spinal cord cranial nerve problem. This is beyond the CNS and PNS. We're seeing a pulmonary embolus. We're seeing colonic distension. So we're just worried about some widespread infectious process or malignant process that is impacting this individual. So for case C, like the hunt would be on for the infection primarily and figuring out what infection is causing all this. Maybe I can pass it back to Robbie to just reflexively share what infection crosses his mind.
No, Prof. Rez, I think that this is why it shows the value of schema. So I think I'm literally going through this checklist. And Prof. Rez, I'm stuck by case 3, how the paralysis is just a small part of the story. Unlike the first 2 cases, the patient gets confused before she's intubated. And so her brain goes offline. She also, in addition to being weak and confused, she also has autonomic features with constipation. So much of her neuroaxis is affected. It's hard not to think if so much of her neuroaxis is affected and I can't see it, I think she probably has a substance. And the reason I say that is I think it's the most, oh my God, most demyelinating diseases behave and say restricted to a specific territory. It's very unusual to have a demyelinating disease that affects the brain, the spinal cord, and the autonomic nervous system at the same time. So, for example, most patients with Guillain-Barré do not have colonic involvement, let alone brain involvement. So that's why I'm reluctant to move to the end of the schema because it doesn't fit Guillain-Barré very well. So I'm pushing myself to see where is it anywhere here. And because of her HIV, I'm right there with you. I'm like, oh, could this be an infection? But I worry she actually is hitting some hits for porphyria. She's a woman. She just got exposed to Bactrim, a trigger. She's got hyponatremia with SIADH features. She got confused before she got intubated, and she's constipated. And so I worry that her HIV might be distracting me to over prioritize this, and that she might have acute intermittent porphyria. Either way, I think there's a substance involved here. So I don't think I would initiate treatment for Guillain-Barré. The one thing that I'm open to, Prof. Rez, is she has Bickerstaff encephalitis, which is a cousin of Guillain-Barré because she has some brainstem findings with the facial paralysis. So in her, I'm the most confused, just like you. But I would definitely stare at her urine, which is something I don't do as a hobby, but I think to see what happens to it when we collect it as it gets exposed to light. And I would probably consider uh I would call Hemonc and see, hey, should we give her Heman or do something like that? But I'm curious now that now that I've babbled about AIP, how is that hypothesis fitting in your brain?
But first of all, I think that's just a testament to how well you've like learned a rare disease to even consider it in this circumstance. And I think that yeah, like face value, all the points you made, like map onto that illness script. But if I'm being authentic to like caring for the patient, I think like the PE, the history of HIV, everything wants me to rule out just something way more common before landing there. But the fact that you said it, I wouldn't be surprised if we eventually end up there for all the reasons you mentioned. I think that's a terrific thought. But at this point, honestly, I would just be rushing towards an LP if it hasn't been performed and doing like an infectious workup to make sure I'm not missing some kind of, leptomeningeal carcinomatosis, for example. And the fact that she has a PE, like it's making me think that there's some kind of inflammation and making me pause.
Yeah, just probably just to acknowledge that I might have gotten it completely wrong. I thought the LP was normal in her. Otherwise, I like I said in the previous aliquot, I predicted her LP was positive, and I was wrong. I think Zachary, do you mind confirming that? Is it LP in case number 3?
Just a sec.
Because ignore
She
AI
had high protein
high
only,
protein.
no
I see.
cells.
Tricky, Prof, right?
That's really helpful because I'm just reading what's on the whiteboard, not to say that they're doing a bad job scribing. Now with that information, like if the CSF is not inflamed, then now all of a sudden, like less common causes definitely warrant our attention. And Zachariah, there was no lymphadenopathy in this patient. Dude, it may be a good hit.
A big counter argument, I think we should acknowledge it, is that she has a sensory level. That doesn't make sense for AIP. Unless you Google ChatGPT it and the acute setting, they can get a sensory. All these cases are very, very, very difficult.
On it, Captain.
What do you have next, Zachariah?
Awesome. So case A, the patient was actually extubated within 24 hours, was treated with IV magnesium and IV potassium, and a final diagnosis in case A made was acute hypokalemic slash hypomagnesemia periodic paralysis. In light of the fact that all other labs and all other tests,
Robbie, can you
notably
give us a
thyroid
Sue?
functions, came back as normal.
After each of these, can you give us a Sue?
Case B, the nerve conduction studies showed slowed conduction and a classical demyelinating pattern, and the MRI and CT brain was all normal, and all other labs were normal, aside from the fact that the CSF showed albuminocytological dissociation. Oh, and just to note, all three patients were empirically treated with polygam immunoglobulin, empirically. And then in light of the fact that patient A improved so rapidly with the correction of the electrolytes, that was the diagnosis for case A, secondary to acute gastroenteritis. Case B, then, like I said, nerve conduction studies showed that pattern, MRI, CT brain, all normal. And then case C, interestingly,
wait, Zachary, so case
patient,
2 was Guillain-Barré?
case B was diagnosed as Guillain-Barré.
Sue!
And the patient improved. The patient was treated, I think, I have it documented here. The patient completed 5 days of polygam, improved respiratory function, full recovery with physiotherapy. Diagnosis was Guillain-Barré. Case C, the patient was admitted to the ICU for several weeks, received polygam, no resolution, normal CT brain, normal MRI, full autoimmune, infective, inflammatory workup, multiple antibodies tested in the serum, in the CSF, all came back as negative. And then at some point in the admission, because the patient presented actually with a family member, and then the family member sort of fell off the bandwagon. But further history was taken from case C, that actually this patient was a known mental health care user and actually had an inpatient admission 2 months earlier for what the family member described as a nervous breakdown. And like I said, in light of that history, a bedside test was conducted and something was sent off to the lab, which then confirmed the diagnosis for Casey.
Oh, I didn't catch that, Zachariah. She was a what user? What did she use?
A mental health care user.
Oh, Rob, are you familiar with that?
Oh, I think she seeks psychiatric
Like a
care.
psychiatric care.
Oh,
You stumped Prof. Red, Zachariah. Yeah. Yeah, I mean, I think, Prof. Rez, I don't, I think the Zachariah is giving us the idea that when we were zoomed out, we learned that the patient had had a quote nervous breakdown in the past. So I think we're studying the overlap of psychosis, possibly, and eventual neurological disease. Yeah, I think that space for me is littered with so many things, including the possibility of catatonia, the possibility of lupus psychosis, with subsequent neurological elements. But acute intermittent porphyria is also on that spectrum. Any other thoughts, Prof. Rez?
Dude, that's brilliant. I love catatonia and I love AIP.
Yeah. I think that the interesting thing about case 3 is everything is not working. The brain, the nerves, the bowel, and then there's a metabolic element to it with the sodium. It just really screams to me that there's a molecule bathing her body that's not making her happy. Otherwise, we don't see anything with our eyes. So what molecule is it is a very interesting question.
Awesome, awesome, awesome. So yeah, you guys nailed it early on. Um, yeah, in light of that history and the history of uh, in the labs, SIADH and the psych history, and the abdominal findings, the urine was actually screened in the light and it changed color. And the urine was sent off to the lab. It showed elevated ALA and PVG, plasma peak levels of 619, which was quite high, confirmed the diagnosis of acute intermittent porphyria. Unfortunately, at this hospital, Heman was planned to be given, but it was unavailable at the time. Patient experienced a partial neurological recovery, but then subsequently it demised. So it was a poor outcome for patients here, unfortunately, due to the lack of Heman.
If I can just reflect before giving the mic to Robbie and asking Zachariah what your main teaching points were. I actually have to go for a doctor's appointment soon. First, I just want to have everyone thank Zachariah. Like, for you to put these 3 cases together and present it in such a way, like, I can't tell you how much it almost makes me emotional to think that, like, yeah, that someone can do that. It's very reminds me of Robbie on RLR. Like, just it takes so much mastery, so much, yeah, so much skill to do what you just did. So thank you for that. And then the second thing is, Robbie, I think everyone needs to applaud you as well. Like, you know, all these cases we do is not just for fun. Yeah, you love it, you're passionate, but for you to have 3 cases, all of them, like, if case C was the only case presented, I think there's a chance I would have arrived at AIP. But to have all 3 cases, every neuron of mine being fired, it just shows like how much you've dedicated yourself and how much mastery you have of these rare illnesses. And look, what would that have done if you were the doctor caring for this patient? Like, at time point 0, you wanted to give heme or you wanted to send the porphyrin labs. It just shows you the power of clinical reasoning. So I think it goes beyond like the impact you're having on so many junior trainees, but actually the impact you would have on a patient. And I bet you those that have seen this in the future, if they see that triad of like hyponatremia, abdominal neurologic stuff, even with a sensory level, which may be true or not, they'll think of it. So I just want to say, like, it's a master hour. It's just so awesome to see you do that.
Prof. Rez, I don't think I have the right things to say to everybody here, but I also wanted to echo exactly what you said about Zachariah. The accomplishment that you are able to do this skill of presenting these complex cases in a way that actually allows us to keep up is well beyond your level of training. Well, anything that I can even imagine, quite honestly, uh, 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 10 years ago. I also want a big shout out to the scribing team for keeping up. It's a very, very difficult thing to keep. And the fact that you already had the board prepared was a very touching thing, quite honestly. But honestly, Prof. Rez, I think the biggest shout out goes to you because what you're doing for Zachariah and what you've done for me. I think those of you who don't know, Prof. Rez is my senior. He's 2 years ahead of me, and we've been doing this for so long that I think people forget that. And I remain and was even more so a very shy, introverted guy, and didn't even know how to like navigate myself in this space. And uh, Prof. Rez carved open so many things for me, and I think you're seeing that part of him so alive and so well. Let alone how well he discussed himself which we all know and love him for, how well and how clearly he teaches and keeps it to the bread and butter the whole time. Um, you can't help but just try to make the world a better place for everybody. And so the fact that your reflections have nothing to do with the medicine and more to do with Zachariah and me is just that's peak, honestly. Living life for other people. There's no better way to live, Prof. Rez. So thank you, honestly.
Love you, man. With
Love you.
that, I'm gonna cry and go to my doctor's
You don't
appointment.
need the doctor anymore. You're healed, Prof. Rez. Have a good day, okay?
Take care. Thank you guys so much.
Um, and on that emotional note, I think I'll hand the mic to you, one of our newest, or not newest, but one of our most recent Academy members. Take it away, my friend. Oh, I think you're muted, Kritika. So please take it away, and then after you're done, I'd love to hand the final word to Zachariah before we end to have his more condensed reflections. Take it away, Kritika.
Thank you for the great case and very great discussion. So today we had a case series of 3 patients who had similar complaints of bilateral symmetrical proximal and distal extremity weakness. And so the causes that were thought of are any obstruction, which could be a vascular or mechanical cause, any compression, rupture, any extra electrolyte abnormalities, or any sudden onset of action of any abnormal molecule. And considering most of the patients had infectious history, so we thought it could be autoimmune process like GB. And also the preliminary investigations that we needed were MRI and labs for any substance or any electrolyte abnormalities and any history of exposure that we needed to ask the patient. And because there were more of peripheral involvement, we were thinking in terms of axonal neuropathy, like diabetes or alcohol, which could be length dependent, or even GB. And so with the differentials were myelopathy versus demyelinating. And when we did an LP, there was cytological dissociation in both case B and C. And Rabi mentioned that in polyradiculopathy, why do you get albuminocytological differentiation is because of the spillage of protein in the CSF because of the inflammation of the roots. And the third patient had history of HIV and was on Bactrim. So Rabi mentioned it could precipitate porphyria, which could explain the diffuse neurological involvement. And also the third case had at a definite sensory level, which could point to a spinal cord lesion. And so LP was thought of because there was involvement of both spinal cord and peripheral nerves. So subarachnoid space could be a likely site of infection. And another differential that was considered was Bickerstaff encephalitis, which could explain both the brainstem involvement and the bilateral facial paralysis. And finally, when we got the diagnosis for the case C, so it was mentioned that the patient had a history of psychiatric illness. So the psychiatric illness component and the weakness involvement could point to acute intermittent porphyria, and which was the diagnosis.
I don't know how you did that. That is one of the hardest things to summarize these 3 cases and keep them all straight. That was outstanding, Kritika. Thank you so much. I think this is the first time I've heard you do teaching points myself. I know you've done them before, and I'm very, very impressed. Thank you for an awesome job. But we
Thank you.
cannot finish this session without hearing your crystallization of these cases, Zachariah. Take it away.
Thanks for the great discussion. Yeah, you guys are really. I don't know what more to add to that wonderful teaching points, but yeah, I just want to say a huge shout out to you guys for creating the safe space for students all over the world, and sort of democratizing medical education and medical learning. It's a huge accomplishment what you guys have achieved. And like I said, I was only able to put these cases together through lots of learning from you guys and learning from all various schemas. And anyone out there like who's wants to present a case, please bring your cases, join the academy, join the YouTubes, try and attend the live sessions. It really, really does a lot for your medical education and your clinical reasoning. As Rabi said in the academy, like it literally puts your clinical reasoning on steroids, and you can only learn. And it's a really, really safe and nice space to learn medicine and learn clinical reasoning. So yeah, nothing much to say to the cases. Three excellent cases. I learned a lot from these cases. Very sick patients. Fortunately, good outcome for two of the patients. Unfortunately, due to lack of resources, the third patient couldn't get the treatment that she needed, but learning for all of us. Yeah. Thanks a lot, guys.
I couldn't have said it any better. We are all so much better because of each other's presence, each adding to our lives, and the invitation is for everybody, and the process is simple. Present a case and hang out with us, and that's it. You may ask, well, why do you need to present a case? That's our lingo. That's how we talk to each other. That's our alphabet in our language. So I'd love to engage with you in that. Thank you all so much for a really, really special hour, and I look forward to seeing you all later.